So let's kick it off. So barriers to patient access. There's some obvious ones on here. Whenever you talk about barriers to patient access with people that know nothing about healthcare, you're going to get some of the obvious topics. The price of healthcare, right? Insurance premiums, the macro economy that we actually live within today. But then there's some hidden elements. There's the hidden elements around transportation and lodging needs, the cost and demands of psychosocial support. And probably one of the most forgotten ones, unless you actually are close to it, is the administrative burden and the manual and fragmented processes that exist today to break down those barriers. We're going to come back to that topic, but unless you're really close to it, unless you work in the business that we all do, a lot of people probably don't even know that this phenomenon exists. So here's some facts. Again, these first 7 to 8 slides, we're probably not going to say anything that's going to be like, oh my God, I didn't know that. Hopefully it's just reinforcing things that we already know, but it's defining very clearly the problem that we're all inspired to address. These are super sobering statistics. So ultimately, at the end of the day, financial toxicity, if you don't think it's real, these stats are going to prove that it's extraordinarily real. Patients are foregoing their medications. Patients are cutting their pills in half. Patients are foregoing medical care in its entirety. So you have 29% of adults report not taking their medications prescribed because of the cost. 19 didn't fill a prescription because of the cost. 12% are cutting pill capsules in half. 84% of physicians report having patients go without medical care because of the costs. Hopefully that hits you right in the heart. But what's interesting is, and the advocates in the room, I can only imagine what you guys go through on a daily basis. We hear the stories. We hear the stories about patients with tears in their eyes that literally just got told the worst news of their life, that they have cancer or that they have some other type of complex diagnosis. And they say back to the financial counselor, financial advocate, I have a decision to make. I'm either going to go bankrupt or I'm going to die. That's a decision facing people every day. What all the advocates in this room hear that story every single day. I think the previous slide talked about some of the challenges with patients who made the decision to forego the medication. But look at these statistics for those that choose to move forward. You can see the financial impact to them. 37% of patients used all their savings to pay their bills. 31% took on credit card debt. The biggest one, 26%, were unable to pay for basic necessities like food, rent, and heat. I heard a story about something in another session where we were talking about $100, right? And maybe some people in this room would be like, oh, what's $100 going to do? That last statistic is pretty interesting. Ultimately, at the end of the day, $100 matters because people can't afford to eat. They can't afford to heat their home. Ultimately, these statistics very clearly denote how problematic the situation is. Now, what's coming to our attention furthermore, beyond financial toxicity, is the issues with health inequities and disparities of care. What you can see here is that socioeconomic status is a primary driver of health inequity. I think we, again, are beginning to understand this and know this. But what does this actually look like at the end of the day? Again, these are sobering statistics. 12% higher cancer death rate in people living in poverty compared to those not. 17% higher cancer death rate people living in rural areas. 12% higher cancer death rate in Black women compared to white women, despite an 8% lower cancer incidence rate. The statistics don't lie. We've got an issue not only with financial toxicity, we've got an issue with disparities of care and health equity. Now there's hope. It's pretty cool to be at a conference where there's 800 people, I heard, that are dedicated to this topic. It kind of shows that this is real. It shows that there's a lot of inspired individuals that want to make a difference and make a change. We know there's money available, charitable foundations, manufacturer programs. We are beginning to make a difference, but it's going to be bigger. We need something more systemic, something more substantial to make a change. Now, I want to tell a little story about this administrative toxicity that I was describing earlier. So my partner and I, Joe Buffone, and I formed the company about 7 years ago. And we formed it based on stories that we heard from a lot of financial counselors in the room today. And what we would hear, again, I go back to that story of the patient being told the worst news of their life. They have metastatic non-small cell lung cancer, stage 4. And as they walk out the door being told that it's going to be a very expensive journey, and it may take 4 to 5 weeks for them to get on medication. And again, the obvious is we understand why those things happen, but the lack of obviousness was hidden behind the curtain. So walking into the back hallways and actually watching with clarity what a financial counselor actually did and the tools they had was crazy. Ultimately, at the end of the day, we would have them open up their laptop. You guys have seen it. The Google Chrome browser would have 150 windows open. Every single pharmaceutical manufacturer website open, charitable foundation websites open, insurer payer websites open, all with their own login IDs that you have to keep track of. And then it didn't matter how big, how small, how sophisticated, how not sophisticated, every practice institution had their own version of an Excel spreadsheet to try to keep track of all of this stuff. And then in the corner of the room, there would not only be one fax machine, but we all know there's several fax machines. That's crazy. I think it ultimately clearly defines why we have such a problem. There's the obvious pieces, right? Healthcare costs, insurance premiums, the macro world. We can point to all of that. But there's some basic, obvious pieces as it relates to the administrative toxicities that cause a real problem. But as you peel that onion back, what are we going to do about it? Do we can hire more people? The costs begin to get out of control. We walk into institutions where they say, we have no financial counseling arm. We can't afford it. You have situations where practices are reactive. We call it proactive versus reactive approach. They only talk to a patient about their financial well-being if asked, or if the patient expresses a need. These are some of the most premier cancer centers, rheumatology centers in the United States are struggling with this problem. Now, when you talk about health inequities, think about this. Although not intentional, when we ask patients for their consent, when we actually force them to have to sign an application for a free drug program, for example, go back to the previous slide if you think about what are we doing? We're potentially disadvantaging those that live in rural communities, that live 60 miles away from the clinic. What if we come up with an app that they can sign on their cell phone? They don't have a cell phone. They might not have internet. So there's things that are out there that are administratively being done, maybe with good intentions, but ultimately have an impact as it relates to financial toxicity and health inequities. So what are we doing about it? Our vision is rooted in one simple thing: no patient left behind. I was actually just talking to people over lunch a little bit about this. Our mission and our vision is that every single patient deserves a financial assistance conversation. And if we as people, as human beings, pick and choose which patients we're going to have a financial assistance conversation, we've got hearts, we've got souls, we're going to introduce bias. And that's not right. Every single patient, it doesn't matter who they are, what their background is, the color of their skin, every single patient deserves a financial assistance conversation. That's our vision. That's our viewpoint. But in order to do that, you need tech, you need scale, and you need efficiency. So our mission at the end of the day is threefold. Every strategic decision that we make, every small decision that we make, we always anchor it back to three things. So number one, clinical intent. Is clinical intent being seen through for the patient to actually get on drug? Are we cutting fat out of the system to actually speed up the process? And number three, is the patient staying on therapy for the optimal period of time? Those are kind of the founding principles that we operate by. So just to tell you, just to briefly, what we do as an organization, because I want to set this up to actually talk about the quantitative data here in a second. So we're a tech company through and through. So we have a platform called AssistPoint that ultimately is a single enterprise platform that works with and interconnects with EHR platform, billing system, dispensing pharmacy, you name it, to actually create one environment for financial counselors and advocates to do all of their work. And the words we think about, we use 4 words when we describe our product: search, enroll, track, and analyze. So number 1, search. So how do we create a mechanism by which I can more effectively understand a patient's circumstance and identify the right program for that patient? 2, how do I seamlessly allow that counselor or advocate to enroll patient into whatever program? How do we work together as a community with pharmaceutical manufacturers, charitable foundations to digitize that process? Then moving over to track. That's where I think we sometimes miss in the world of financial assistance. We put so much emphasis on finding the right program and enrolling a patient into the right program. You almost say, all right, we're done there. You hear a lot of people talk about that. Our viewpoint is financial assistance is like financial assistance cycle management. So it's another thing to then get the patient a card and to set it up appropriately in your practice management platform, to get it set up in your pharmacy dispensing system so you actually use it. So the patient doesn't get a surprise bill at the end of the day when they thought they had financial assistance. And then the last thing we do is analyze. So you have to create a mechanism that you measure. You can talk all you want, but ultimately at the end of the day, the data doesn't lie. So we need to create a mechanism for financial counselors, their supervisors, CFOs of institutions to better understand and measure what truly is going on. What we realized along the years is that tech isn't enough. Because again, we would hear those stories from the institutions and the practices that we would visit that quite honestly just didn't have the people. Whether they didn't have the people at all, where they weren't running financial counseling arms whatsoever, or they didn't have enough staff to work every single patient up. So our viewpoint was, how do we actually have a blended strategy where we have tech, but then scale people and processes that we can meet our vision that I described earlier to ensure every single patient is worked up. So what I want to share with you is the data. What is the data telling us, the real world data telling us, as it relates to the role of tech and tech-enabled services and the difference that it could make? So we looked at three items here, and I'm going to give a disclaimer. Some of this is financially heavy, and I always go above and beyond to say, yes, it's financially heavy, but you can track this all the way back, ultimately, at the end of the day, to the patient impact. So I want to say that each time we go through each of these items, yes, there's financial measurements that we're going to have here, but ultimately at the end of the day, what does this mean to that patient story that I described earlier? So the 3 items that we're going to walk through today is post-assist point, call it post-technology deployment. We actually see practices, institutions have higher financial assistance collections rates pre them actually having software. Furthermore, we actually see a more durable response. So year 1 may look good, year 2 gets stronger, year 3 even stronger. So we'll talk for a minute about that. The next one is free drug utilization is more optimized or more optimally managed using technology. There's a place for free drug. I think we would all agree on that point. Free drug is a very good thing if used appropriately, but there may be other options for that patient that may come up along their journey. So continuously evaluating options for a patient beyond just their initial clinical intent is critically important, and we'll talk a little bit about that data. And then finally, when you sprinkle on both tech as well as tech-enabled services, we see a substantial impact in terms of lowering costs, so doing it in a more efficient way, but hopefully realizing a more powerful end result, higher outcomes. So let's take a deep dive into each of these. So we're going to start off with financial assistance collections increase with assist point. And again, the way we formulated this, we developed a hypothesis that post-implementation, on a per provider basis, we would see the collections actually go up, and we would see it go up even more over time. So this is what the data suggested. So the top graph is a cohort of practices that went live with the software in 2019. The bottom grouping is a cohort of practices that went live with the software in 2020. So we wanted to give enough time to actually produce the results. So what you can see in the 2019 cohort is the first year after implementation, collections went up 22%. And you can see how that kind of climbed over time. Similarly, for the cohort of practices in the bottom graph that started in 2020, you can see a double-digit % increase out of the gates and obviously a further increase in out year. The important thing to realize here is year 2 in the first cohort and year 1 in the bottom cohort. I think everyone kind of lived that. That was COVID. So ultimately, at the end of the day, you may see some muted responses. We're going to report the data as it's shown, but obviously keep in mind, COVID may have muted some of the impact that we observed. So the second finding here is free drug utilization is more optimally managed via technology. And again, our measurement here is we want to see more patients get access to therapy, which drives, obviously, patients getting on drug. But we want to see if patients are actually converting to other sources of funding post, let's say, getting on therapy. So the first graphic here actually looks at a cohort of patients that were enrolled into a specific program in our network that was digitally enabled. So just to talk about that for a second. You guys all know free drug applications are typically 3, 4, 5, 6 pages long, very arduous process. What we do is we digitize that experience. So in a lot of ways, we'll pre-populate the form because we're connected to EHR, practice management platform. We allow for a more seamless user experience. So what we theorized is that when you make it easier to do, the theory would be that you would actually see an increase in overall utilization of free drug. Again, appropriate utilization. So we looked at the 2-month period post deployment of this program, and you saw a substantial increase year over year. Now, probably the more impactful analysis is this. So we all know charitable foundations have a concept of a wait list, which is great. So patients can get in line, let's say if no funding is available, they can get in line by joining a wait list. We've developed a tech-centric similar process called a watch list in our world, where you have a patient where clinical intent has been determined. So patient's going to be starting on drug ABC. Let's say there's no funding available. There are no options available, and this patient, let's say, may be a candidate then for free drug. What we're going to do is tag that patient as part of this watch list to evaluate them for other sources of funding if they downstream become available. So that's what the watch list does. It's kind of a tech-enabled way to really continuously monitor this patient. So what this analysis did, the orange bars, just to be clear, are patients that were not put on the watch list. So these are patients that enrolled in a free drug program that were not tagged. The blue bars represent patients that were enrolled in a free drug program that were tagged on the watch list. And what we measured is, within 180 days of starting therapy, what % actually converted to an alternative program. In this case, let's say, may have converted to a charitable foundation copay grant. And you can see there's a 3 times difference between these numbers. Now, this topic is to explore the impact of digital solutions, tech-enabled services. Let's all take ourselves out of this room. If you have to understand the tasks of what somebody would have to do if they didn't have tech, right? So you have to know that you enrolled this patient into a particular program. You put them on some type of list, whether it's an Excel spreadsheet, Scratchpad, what have you. Then you need to keep that ordered by a certain, let's say, disease type or diagnosis, maybe by drug name. Then you have to consistently evaluate each and every fund when it becomes available to go back to that list to then submit a paper copy. Again, I think we all understand we're not giving people the right tools to actually do the valued work that they do every day to help ensure that no patient is left behind. So we're encouraged by these results that tech actually does matter. If used appropriately, tech does make a difference. So we'll move on to this last piece here. So this last piece kind of looks at Paro in our world is tech-enabled services. So it's where our people employed by us use our technology and our processes. So think of this as like scaled human resources as well as scaled processes using tech. Could that make a difference? Could you actually see lower cost? Could you see higher outcomes is really what the theory was that we wanted to measure. So I'm going to go back to the vision statement. We want to ensure that every patient deserves a financial assistance conversation. Every patient gets that. So this top right graphic, what that's looking at is after implementation of a tech-enabled services program, what happened to the numbers of assessments? So we're actually looking at the same time periods. You're just looking at 2 different years. And you can see a staggering increase. So the number of patients that actually had a financial assistance conversation went up by over 300% year over year. That's a median across all practices evaluated. The bottom graphic, what that's describing is the total dollars awarded. Now, we know every patient that you assess might not be appropriate candidates to get enrolled into a program. But ultimately, at the end of the day, we still saw the numbers increase substantially, so about 150% year-over-year growth, when again, tech-enabled services combined with tech was installed and implemented. This slide is kind of the crescendo, I guess I would say. Again, going back to if you believe in the issues that are in play, that it's unsustainable to have people with a lack of tools ensure that all patients are worked up in a positive way. You're going to have reactive tooling. So it's unsustainable to continue to throw dollars at this without tech or standards. This is a graphic that describes kind of call it tech-enabled services, post tech-enabled services, what actually happened. So the top row of this representation showed that this practice, as a case study, spent about $3.3 million to get financial assistance. So that's people, it could be license fees that they're buying a bunch of different things. That's the fees that they're outlaying to drive financial assistance. They collected about $4.2 million in total collections. Post, again, tech-enabled services, you can see actually their fees went down. So the amount of money that they were actually spending to do this work became more efficient, but the actual impact tripled. So the amount of collections actually went up by 3-fold. So ultimately, at the end of the day, hopefully this evidence, these are early results. We want to do more. We want to measure a lot more of this stuff. But I think everyone thinks that tech matters. They think that tech-enabled services matter. We wanted to actually show it and prove it and run research to actually show that it does matter to a very significant extent. So the last thing I'll show here is we have this thing called AP Connect. This is where we actually work with charitable foundations and manufacturer programs to digitally enable communication flow. So let me give you today versus now, or yesterday versus today. Yesterday, let's say, you worked with pharmaceutical company A by going to their portal, right? Or sending them faxes. And that's how you kind of had a communication flow between the two of you. And then you would downstream put it in your Excel spreadsheet. Tomorrow, with our environment and what we do from a technology perspective, we allow for that digital connection to result in a communication flow in one single environment. So instead of having to log into pharmaceutical A's website, B, C, D, E, F, G, H, I, J, K, and the list goes way on, more letters to go, you can do all of that work in one environment. It's in a standard way. All the enrollment forms look the same. It's a way that you get information back in a very consistent medium. So what we wanted to prove is this matters. To actually prove that financial toxicity is actually going down as a result of these initiatives. So what we looked at in this measurement was, are patients actually staying on therapy longer? So pre-post, after we actually deploy a digital integration, do we actually see that as a result of that, patients are actually staying on therapy longer? And that's what this results looked at. So we actually evaluated 15 drugs all medical benefit drugs. So these were infusion-based products. They included a mix of branded therapeutics, biosimilars were in the mix, supportive care agents. And what we found is that the average impact was 1.15 treatments longer. And when you actually dive into the results, 14 of the 15 brands actually showed a positive impact. Now, we would love to get more scientific and rule out any clinical biases between the cohorts and so forth. But again, I think the overwhelming evidence is showing that tech and tech-enabled services truly do matter.